I welcome you to the Race Against Dementia Data Challenge 2 launch. My name is Sara Benishova, and I am the project coordinator for the Data Challenge project at the Brain Health Alliance for Research Challenges at University of Glasgow. I will be giving the introduction presentation today. I will walk you through our schedule for the launch, introduce you to our sponsors and partners of the Data Challenge, and I will talk you through some of our core objectives for the project. I will also talk you through the timeline of the challenge and lastly point you to all of our resources and show you the application process. So for today's presentation, as I mentioned, we will start with a short introduction of the project. Then I will hand over to Professor Terry Quinn, who is the director of Brain Health ARC, to talk a bit about some of the key takeaways from Data Challenge 1 and this year's prizes. Then we will move on to the data sets we will be offering as part of the challenge this year, and those will be introduced by Dr. Jenny Burton and Kali Mabramati. In the end, we should have about 15 minutes or so to answer any questions you might have. So none of this would be possible without our sponsors and partners. We feel very lucky to be partnering with 3 amazing organizations for this challenge. And our first sponsor, whose name bears the title of the challenge, Race Against Dementia. Race Against Dementia were founded by Sir Jackie Stewart, OB, in 2016. And they're a global charity dedicated to accelerating progress in the prevention, diagnosis, and treatment of dementia. The charity funds and supports outstanding early career researchers worldwide. They equip them with Formula One-inspired mindset, training, mentoring, and tools to drive innovation and collaboration across disciplines. By challenging convention and adopting the speed, precision, and teamwork on Formula One, Race Against Dementia is transforming how dementia research is done and pushing us closer to a cure. Our second sponsor is the Macdonald Charitable Trust. Macdonald Charitable Trust was founded in 1978 by Macdonald, known as Derek. And they support charities across Scotland that make a real difference to people's lives. Each year, the Trust provides up to £4 million in grants to organisations working to improve outcomes for children and adults facing multiple challenges. Guided by a strong sense of family and community, the Trust takes an active interest in its beneficiaries. They build connections, foster collaborations, and help charities across Scotland to achieve their purpose. The grants all sit with a set of agreed funding themes, amongst those being tackling child abuse and neglect, visual impairments, neurological condition, animal welfare, or medical research. Last, but definitely not least, we are very excited to be partnering with Dementias Platform UK for the challenge. So Dementias Platform UK, or DP UK, in short, is a partnership of 27 organisations spanning academia, industry, and the third sector, supported by the Medical Research Council. They are based at the University of Oxford, and they bring together world-leading expertise to drive progress in dementia research. Through their data portal, they provide researchers with access to high-quality, dementia-focused health data and powerful analytical tools. They help to bridge the gap between scientific discovery and new treatments. And through their other initiatives, like their trials delivery framework and experimental medicine program, DP UK is creating a collaborative environment where researchers can better understand how dementia begins and accelerate the development of effective interventions. Now I would like to talk a bit about the challenge itself and some of its core goals and offerings. So when we look at our goals, we sort of divided them into 3 main pillars. And with this challenge, we are opening up existing data sets and dementia research to researchers across UK, either with or without prior experience in dementia research, but mainly what's tying them all together is an interest in aging and brain health. We're looking to act as a sort of connecting agent for researchers in the UK and worldwide by creating new collaborations. We are aiming to bring interdisciplinarity into dementia research. And lastly, we are hoping to offer an unprecedented support to your dementia research by providing resources to efficiently utilize the available datasets and shine some spotlight on some particular datasets which we think are full of potential. So what is it that we are actually offering with the data challenge? We're offering you a curated collection of datasets, each of them unique. The challenge also offers you a structured timeline that helps you keep projects on track. Again, something that will keep popping up, but it's so important, is that we will offer the access to end-to-end support. This includes forming your research questions before you even apply, to analyzing your data, to communicating your results. And lastly, we believe that collaboration is one of the driving forces of progress. And whether you will be applying as a team or approaching us as an individual, we will be aiming to recognize researchers with similar interests and questions and establish new connections. All the points that I mentioned are something which makes this data challenge unique to other opportunities. We try to make data as easy and accessible as possible to motivate researchers to take on dementia research, and we emphasize the involvement of early career researchers in brain health research and deem inclusivity and multidisciplinarity as important values. Again, doesn't hurt to stress again, but we think it is one of the most unique offerings of this challenge, and that is the opportunity to access the support. And this is support that will lead you throughout the whole life cycle of your project. We also acknowledge how important it is to reward hard and innovative work, and this challenge offers the opportunity to present your research at the final showcase and be accordingly recognized. Now, let's look at the timeline we have created for this challenge. Right at this moment, we are finding ourselves at the very left side of the scale. That is at the launch of the Data Challenge 2. The second important date on the timeline is the deadline for receiving applications, which is the 31st of January 2026. We have also set out 2 dates for you for networking sessions. These sessions will be a space for you to network with other researchers working on the challenge, but also to ask questions not only amongst each other, but to ask questions with our team present to clarify or assist with anything you might need. Those 2 dates are the 9th of March 2026 and 10th of June 2026. Now, the 23rd of October 2026 is when the data challenge closes. So exactly a year from now. And this deadline is for results submission. So after this date, we can no longer guarantee you our in-house support. However, the access to data remains available. And lastly, on November 20th, 2026, we will hold a challenge showcase where everyone will present their findings. So how do you apply for the challenge? Very easy. You will need 3 documents. First, the application, where you outline your project and its participants. Second, there will be the support agreement, where you choose which type of support you will need from us. And we'll also need the CV of the principal applicant. All of those will be sent to me. Something we want to stress again is that you can reach out to us even in the pre-application stage. you can discuss your ideas with us or simply just ask for help with defining your project or anything you might need. The deadline, again, is the 31st of January. Everything will be in the resources for you to reference to back later. So speaking of resources, everything we hope you might possibly need at this stage is at the Brain Health Arc website. If you don't find your answer at the Brain Health Arc website, please do reach out to me and I will try my best to get back to you with an answer. But anything, including documentation, application process, the timeline that you just saw, and some frequently asked questions are on the website. Yeah, so that's it for me. Thank you very much. And I will hand over to Terry.
So I am Terry. I have the honour and the privilege of leading both this challenge and the Brain Health Arc. And I'm going to be really quick, because I know it's not me you're here to hear from. I'm going to be really quick, just giving you a little bit of an insight into how we got to where we are and really my vision for where we're going. So I have to put this in the context of the Scottish Funding Council Brain Health Arc. So I lead the Brain Health Arc. They're funded through Scottish Government. And we have a remit around building capacity, supporting early career researchers, sharing resources, and just trying to raise standards and improve our knowledge around dementia and brain health. We have a mission statement that's at the side there, but basically this challenge very much encapsulates everything that we try and do within the ARC. So what have we done in the ARC? We've been running for a few years. Well, we've done quite a lot actually. So we have been shaping policy. I have found myself in Holyrood, Bute House. I've found myself in London and Whitehall, talking to politicians, talking to civil servants, and starting to shape policy around dementia, and that's already starting to have an effect. We've also been trying to create community, and if I look back on Data Challenge 1, I think one of the great things we did was build a community of people with an interest in dementia and data. And we've been creating community through meetings, through newsletters, and lots of other activities. And if you're not already on the Brain Health Arc mailing list, I would encourage you to get on it now. We really do want to support people who are earlier in their research journey. We have seed funding, we have small grants, we have mentorship, we have educational meetings, and hopefully anything that you might need. And the other thing that we've always tried to do within the Brain Health Arc is have an ethos of sharing resources. So when we have been given money, we've shared that out with the community. And when we were given a big data set, which was BioHermes 1, we thought, let's share it. Now, everyone talks about open data, but let's be honest, some open data are more open than others. So there are data sets out there, but they're not always completely open to someone that has an idea that could perhaps be assessed through that data. And there's lots of reasons for that. It might be that the data has an access fee, or there's a really arduous permissions process, or the format of the data is impenetrable, or you need software that's not standard, or the data access, although open, really isn't open at all and it's restricted. What we wanted to do with our data challenge is take a data set and remove all of those barriers. So it really was open to anyone out there that had an interesting idea that could potentially be answered by the data. But we wanted to do more than that. So Sarah mentioned that really our vision was to offer end-to-end support. And what do I mean by that? Well, that's more than just helping people with analysis of data, because we recognise there are lots of points in the journey from when you have an idea to when you have that research publication where people could benefit from support. So in the challenge, we are offering support at all of those points. We can help you develop your question. We can help you find a team of people to work with. We can help you choose the right data set. Once you have the data, we'll help you manage it. And of course, we're going to help you with the analysis and interpretation of the results. We also want to do more than just have people working with data. We really want to enhance people's CVs, and we will be doing that throughout the life course of the challenge. And when you're all done, we want to help with dissemination, and we want to help people use those data to further their careers, to go on to have applications for fellowships, grants, and all of these other things that are incredibly important. So the resource that we were given for Data Challenge 1 came from our partners, the CRO, the Global Alzheimer's Platform. They gave us data from the BioHermes study, and a lot of people wanted access to those data because you had data from over 1,000 participants, many of them from populations not usually included in research. So that was a real USP of that data set. And there were lots and lots and lots of biomarker data. And the way last year's challenge worked, GAP gave us access to BioHermes for 1 year exactly. We opened up the data and we supported people to work with those data for the 1 year. And if I say so myself, I think it was a success. More than 100 researchers applied, many of them forming teams. They came from 29 institutions. And by bringing people together that hadn't worked before, we created 6 new project teams. Now, people are still reaping the benefits of working through Data Challenge 1, but I'm already aware of 5 people who have won prizes that we've supported, and I know other people have won prizes for other things. I'm aware of 10 papers that are submitted or very close to submission. And I'm also aware of 4 people that have used their BioHermes data to support further large-scale grants, some to UKRI and some to NIHR. So we really are using the data challenge to build the community and to work towards our common goal of understanding dementia and brain health. And again, if I say so myself, I think we did have some impact. What we were doing by opening up data completely was relatively novel. And that was picked up by lots of people. It was picked up by the press, even by TV channels that I've never heard of before. We were invited to talk about it at AAIC, and it featured in an edition of Scientific American. So lots of people were taking notice of what we were doing with Data Challenge 1. I spoke about influencing policy. For me, one of the really important and humbling things about Data Challenge 1 was it put data very much in the viewpoint of Scottish Government. Data Challenge was mentioned in First Minister's questions, and not only because of Data Challenge, but in part motivated by Data Challenge, Scotland is now taking steps towards having data-informed dementia policy. And I've got the real privilege of chairing the Scottish Government Dementia Data Group. And you can see some information about that group here on the slide. So, Data Challenge 1, I think, was a success, but we're always in listening mode. We're always wanting to hear feedback for how we could do things better. And the community were vocal in their feedback. And there were some common themes. Lots of people said the challenge was good, but 1 year wasn't enough time to really get to a paper that was ready for publication. People said the data challenge was good, but it felt a bit Scottish. People said they were interested in the data challenge, but they felt they couldn't really get involved because they hadn't quite worked up their question yet. So for Data Challenge 2, we want to tackle all of that. We are not going to put any time limit on data access. There's a limit on the support that we can give, but the access to the data will not be time limited at all. And although we're encouraging UK teams, we're very open to international partnerships within those teams. And to help those people who maybe have an idea that's not quite a question, we're providing much more help at those early stages in refining the question and making the question suit the data and the data structures that we have within the data available. There was also some feedback on the data itself. BioHermes was really, it was an amazing and transformational data set, but it did have some limitations. And so we had feedback that people wanted more longitudinal data. They felt BioHermes was very biomedical, and they wondered if we could have a data set that had more of a social care lens. They wanted more cognitive test data, but they still wanted to keep the biomarkers. So my plan for the second data challenge was to offer more than one data set, because I don't think one single data set could speak to all of these requests that we were getting from the community. So as you're going to hear from Jenny and Callie in a moment, what we're offering here is really a data buffet. Applicants will still have access to BioHermes, but we'll also be working with the English Longitudinal Study of Ageing, ELSA. We'll be working with Prevent Dementia, and we'll be working with the Virtual Care Home Trials Archive, which is a unique resource that hasn't been surfaced in this way before. So I think that's really rather exciting. Now, Sarah had tantalised you by saying, as well as talking about Data Challenge 1, that I was going to talk about prizes. And I think prizes are actually a really important part of that dissemination and next steps. So what are the prizes we're offering? Well, we're not offering cash prizes, we're offering support to allow people to present the cool research that they've performed as part of the challenge. We're going to support people to come to our showcase event in Glasgow. We're going to support people to come to the Scottish Dementia Research Conference, one of the best dementia conferences in the UK, if I may say so. And we're also going to be supporting people to present their work at an international conference of their choice. You've got to be in it to win it. So if you want to be in the running for those prizes, we want you to have submitted at least an abstract to present at our showcase event. So I'm just going to finish really where I started, reminding people that all of this is part of our mission in the Scottish Brain Health Arc. Please, if you haven't already, have a look at our website, have a look at our YouTube channel and join our mailing list. And by joining our mailing list, you'll find out about the Data Challenge and you'll find out about all the other really cool stuff that we're trying to do for the community in Scotland and in the whole of the UK. So with that, you'll be pleased to hear I'm now going to stop talking. And I think, Sarah, to keep me right, I'm now handing over to Jenny.
Thanks. So I guess I'm here to introduce the Virtual International Care Home Trials Archive, which is one of the new datasets that's available for consideration as part of the challenge this year. So to do that, I'll tell you a wee bit about VICTA as it's known. So unfortunately slightly misnamed in that the I is an aspirational step at this point, as at the moment we are an archive of UK care home trials, but trials that have been done involving people living in residential and nursing homes across the UK, in which an intervention has been tested and appropriate follow-up taken place. All the trials are published, all the trials involve adults, those aged 18 and over, and all have been completed since 2010 and had an individual sample size of at least 100 people to make sure that we had quite a diverse pool included. VICTA resource is part of the wider Virtual Trials Archive networks, and those of you who've been working in sort of similar areas for a number of years might be familiar with particularly the stroke resource VISTA. I guess a slight difference from some of the other data sets in that one of the principles underpinning the Virtual Trials Archives is that the trialists who've contributed data have an ongoing role in approving projects that make use of their data. And it's only the control arm of the data which are available from an outcomes perspective, so that we're not getting confused about what the trial was originally trying to do and the impact that might have on those outcome measurements. And access to the individual variables is based on them being reported and measured consistently across more than one trial, rather than just providing the same trial data set which is already published. So there's two kind of key papers for people who are interested in finding out a bit more about the evolution of VICTA, which came about through the work of Lisa Irvin and Maizoon Ali, and was embedded within a wider project called the DACHA study about developing a care home minimum data set. So we have both the protocol for gathering the data and creating the archive, and we've got a data resource profile that helps summarise some of the variables and maps out what's available in different trials, albeit since then we have had an additional trial join the archive, so the paper doesn't have quite everything in it, as we are trying to be a live resource, somewhat impeded by the COVID pandemic and the impact that had on recruiting people living in the most vulnerable settings. So the data which are in VICTA come from 7 completed UK care home trials, and one of the strengths of the data are that they look at a range of different domains. So 2 trials that were interested in medication and the role of pharmacy, 2 trials that took a real interest in dementia-specific topics and provided interventions, but also a study about urinary incontinence, of the largest Finch about falls prevention, and the most recent study that's not included in the summary, that from Princess, which looked at the use of probiotics in care homes. So in total, we've got data from 5,984 people who lived across 331 care homes, and the common data are around demographic characteristics, diagnoses, information about the care homes, and resident outcome measures, and broad range of things that have been used, but some measures that will be familiar to those looking at things like function, including the Bartel Index, quality of life, using a range of measures, but most commonly EQ5D, and some dementia-specific measures around cognition and level of dementia. So I guess the contribution that VICTA can make is quite specific. So the care home population are particularly underrepresented in research, and this resource provides an opportunity to make use of existing data that have been collected in great detail through the course of randomised trials, but about a population who are otherwise quite difficult to involve and often quite invisible. It's best suited to really methodological questions about, are we using the right measures for this population? Because quite often a lot of those measures that are described have been developed in community dwelling populations, and we don't know how useful they are for people living in care homes, who obviously are there because they have particularly complex needs that can't be met elsewhere. So some potential examples would be, how do instruments that have been developed for use in community dwelling populations, like the Bartel Index, fare when used in a care home population, and what's the kind of evolution of them over time. Similarly, thinking of measures with more of a dementia focus around the agitation inventory or MMSE, and looking again at how these behave over a period of time. So just some practical aspects to highlight. As I mentioned, we need to secure the trialist's permission to use their study data. So please get in touch with us early so that we can look at the question and make sure that it aligns with the original purpose. The data for VICTA are accessed through a specific trusted research environment based at the University of Glasgow. And at the moment, they are formatted and structured for use in Stata, and they need to be accessed within the trusted research environment. However, that's it for information about VICTA, and I'll stop sharing my screen and hand over to Callie for the rest of the dataset presentation. Thank you.
Hi again, my name is Callie. I ran the first round of the data challenge, and I'm very, very happy and proud to be back to lead data management for this round. Thank you so much, Jenny, for introducing VICTA. I will be introducing the other three datasets, although I must admit Terry did say a lot of what I wanted to say about BioHermes, but that's okay. We're just going to start with the English longitudinal study of aging, ELSA. So ELSA is a longitudinal study, as the name suggests. It has 11 waves that occur with follow-ups every 2 years. So it follows the same cohort of people over 22 years, started in 2002. It's important to say that obviously this group of people ages as time passes, so there are refreshment samples to ensure that the sample actually has the same younger age groups throughout the duration of the study. The target population for the study is representative of adults over the age of 50 living in private households in England, as they were observed in the Health Survey for England in the years 1998, 99 and 2001. You'll see that any refreshments and of the sample throughout the study are also through the same survey. So you can find detailed information in these publications, which you will find linked in the Brain Health Arc website. I'm sure Sarah will go over that in the follow-ups. But let's just take a quick second to visualize what the study design means. As I said, we have follow-ups every 2 years over the span of 22 years. So we have 11 waves. Yes, there's a little bit of disruption around COVID, but there does exist a COVID sub-study for that reason. In some of those follow-ups, you will see a health visit. Where you see a health visit, that is because in addition to the interview and the pen and paper questionnaires that are a common module in every single follow-up, those waves listed here have an additional visit by a nurse who administers an interview and takes biological measures collected by the nurse. So this data set, if we wanted to take a look at numbers and quantify the size of the sample at every stage, you can see here at every wave, the year that it occurred and the sample In blue, you will find where there was a nurse visit conducted and what the sample for those participants for whom we have biological measures is. So in 2004, for the second wave, there were over 9,000 participants overall, and for them, 7,666, fun number, we have biological information. You can see here wherever there was a refreshment sample, it references the source, the survey through which participants were recruited. So if we take a look at the data set structure, the main modalities that are, modules that are consistent at every single wave, that means that you can follow these, the progression of individuals for those topics on all waves throughout the study, are demographics, physical health, lifestyle practices, mental health and psychosocial well-being, social care, social participation, work and pensions, income and assets, housing and consumption, cognitive function, volunteering and caregiving, and expectations. If you're thinking that's a lot, that's because it is. But that's not all. There's still some more, there's some special sub-studies like the life history interview, and in some waves there was the healthy cognitive aging protocol administered, in addition to the availability of genomics data. More detail about this will be confirmed as we move forward to receiving your applications, and you will be able to find an index to walk you through this linked on the Brain Health ARC website. Now, I do also want to say that because ELSA is hosted by DPUK, it is harmonized and can be used with certain other cohorts, and we will be able to confirm more information about that in due course. But let's just move on and discuss what this means for you bringing your research questions to this data set. So the strengths of this cohort are that it's very large. It is a longitudinal study and has numerous consistently available modules. As I said, there's a set of characteristics that are tracked and monitored at every wave. And there's continuous availability of younger participants as the sample is continuously refreshed. That means that this dataset is very well suited if you want to explore directional relationships over time, if you want to investigate holistic individual profiles, if you want to incorporate psychological and socioeconomic information. This is a very rich information in terms of socioeconomic characteristics of the participants. And also, it is very useful if you want to analyze biomarkers and specifically control for socioeconomic characteristics. So with that, I'm just going to move on to the next data set. We're going to go very biological, BioHermes 001. Bear with me if you were part of the first round of the challenge. This is not going to be new to you, but I want to give BioHermes 001 a proper introduction as well. So BioHermes 001 is a cross-sectional cohort. It is 1,001 participants with data collected over 3 visits, but for the same point in time in 17 sites. The target population for this study is typical for assessment in memory services in the US. That means it's participants aged between 60 and 85 years old with no known diagnosis of dementia prior to enrollment. Quota sampling was undertaken for a target cohort of 1,200 participants, and it was from the beginning stratified to balance cognitive subgroups, which we will talk about in a second. But I want to highlight with the unique selling point that Terry also highlighted for BioHermes. It's because this cohort is almost 30% made up of participants from populations typically underrepresented in dementia research. If you're thinking 30% is not a lot, for data sets in dementia, it actually really is. So we must highlight that this is an important selling point. You can read more information about the biomarkers available in this study and the makeup of the cohort in this paper, again, linked on the Brain Health ARC website. And love a consort diagram. Let's take a look at the makeup of the cohort. We're starting with 1,001 participants, and as I mentioned, there's 3 cognitive subgroups, and they're relatively balanced. So we have cognitively normal, mild cognitive impairment, and mild Alzheimer's dementia. And you will see that a stable proportion of each subgroup is made up of participants from underrepresented populations. But let's take a look at how those groups are stratified. First, we must discuss how data were collected. As I mentioned, there were 3 visits, and for 1 point in time, there's cognitive testing and blood sampling. You'll see some of the tests over here. We have the mini mental state exam, the Ray auditory verbal learning test, the functional activities questionnaire, and the geriatric depression scale, as well as other assessments. There's brain amyloid PET data collected for each participant, and where participants did not have access to a standardized PET facility, they were offered a lumbar puncture to collect CSF. And finally, at the third visit, they reviewed the visit 2 results and took further blood samples. With all of those data, participants were stratified into one of 3 groups. The cognitively normal group had no reports of memory loss or related concerns, within range MMSE and RAVLT scores, and no evidence of functional impairment. The mild cognitive impairment group either had an MCI diagnosis, received as part of the study, an MCI diagnosis based on standard criteria, or an MMSE and RAVLT score within the specified range of this slide, as well as some mild, minimal to mild functional impairment in practice. And finally, the mild Alzheimer's dementia, I must note, not disease. Disease refers to the pathology. Alzheimer's dementia refers specifically to the clinical presentation. Participants in this group either had a diagnosis according to standard criteria or had scores within the ranges specified here and evidence of functional decline in daily life. If participants were doing too well in cognitive scores, they were not included in the study. So that means that we have a very rich bio-focused data set. Here we have demographics, subject characteristics, disposition, adverse events that occurred during the study, substance use, nervous system findings, related records, concomitant medications. This is, I must note, also standardized. Medical history, procedures, functional tests, disease response and clinical classification, vital signs, and other information. And this data set also has cutting-edge biomarkers based on the blood samples. Here you can see some of them listed. You'll recognize amyloid beta. You'll recognize amyloid beta 40, 42, and 40/42 if this is an area of interest to you. And you'll also notice p-tau 181 and 217, which are now, according to the Lancet Commission, requirements for diagnosis. And you will find an index for this available on the Brain Health Arc website. But with this, I must also go over how to tailor your research question to Biohermes 001. So we recognize the strengths are that it's a large cohort, it has balanced cognitive subgroups, and we discussed that it has a stable proportion of participants from underrepresented populations in dementia research in all groups. And finally, it has a wide range of blood biomarkers. This makes it very well suited to exploring relationships, but not ideal for causality. It is great if you want to synthesize biomarkers, if you want to explore ways to reduce dimensionality, and if you want to create indices, proxies, things like that. And it is great if you want to control for demographic characteristics. I'm specifically thinking about race and ethnicity, and also cognitive status. Last but not least, I will introduce to you Prevent Dementia. With thanks to my colleague Angelina for helping me create these slides. Now, the Prevent Dementia study is a prospective cohort study of 700 participants in multiple sites that are based in the UK and Ireland. The target population for this study is adults between the ages of 40 and 59 years, as I said, in the UK and Ireland, that were either family of patients at NHS memory clinics, local dementia research registers, or self-nominated volunteers from Joint Dementia Research and the Prevent website. These participants, in the same manner as Biohermes participants, had to have no previous dementia diagnosis, no contraindication to MRI, and within age-adjusted range performance in the Addenbrooke's Cognitive Examination 3. You can find more detailed breakdown on this article, again linked on the Brain Health Arc website. So the Prevent study starts with the screening and it has baseline measures and a year 2 follow-up. Those 2 are concluded, and the year 5 to 8 follow-up is ongoing at multiple sites. So it includes cognitive measures and questionnaires, such as the 4 Mountains test, the Visual Short-Term Memory Binding test, the Addenbrooke's Cognitive Examination 3, biological samples of blood, saliva, urine, and optional CSF through lumbar puncture, as well as imaging 3 Tesla MRI that provided both structural and functional sequences. The dataset structure is thus made up of demographics, vital signs and anthropometric measures, lifestyle practices, psychological questionnaires, cognitive batteries, blood-based biomarkers, and biomarkers derived via saliva, urine, and CSF, and image-derived phenotypes. We may be able to confirm more details about the biomarker modalities available, but that will be in due course. And if you are thinking about how to tailor your research question to Prevent, you must consider its strengths as being a large, younger cohort. It has multimodal biomarkers for the entire cohort at the 2-year follow-up, and it has expansive cognitive batteries. What does this mean for what it's suitable for? It's great if you want to explore rapidly evolving directional relationships, but consider the rapidly evolving part of that sentence. The follow-ups are within 2 years. So if what you're studying is over 10 years, this might be something to consider. It's great if you want to investigate ways to synthesize information across different modalities, and it's great if you want to explore mechanisms that precede older adulthood or clinical symptom onset. Okay, but I've just given you a lot of information, and I think it's very hard to make sense of what to do when two people just introduce 4 different data sets. As an example of what our team will be doing to support you throughout the challenge, I'm going to leave you with an action plan. I'm going to give you a whistle-stop tour of the information you need to know about all of the data sets together and give you an action plan for how to prepare your application. So let's start with PREVENT. We said PREVENT is a prospective cohort of adults, again, between the ages 40 to 59, 700 in total, with a baseline and 2-year follow-up. We have a range of biomarker modalities and cognitive batteries. VICTA is a dataset made up of pooled studies, 7 UK-based adult care home randomized controlled trials of almost 6,000 participants. It has specific measures of function, cognition, and behavior available for analysis if they exist in more than one of the trials. ELSA is a prospective cohort of adults over the age of 50 with 11 follow-ups every 2 years. So that's 22 years follow-up overall, with a broad range of psychological and lifestyle information, blood biomarkers, and socioeconomic characteristics. And finally, we have BioHermes 001, that is a cross-sectional, cognitively stratified sample of 60 to 85-year-old adults, with 30% of this total of 1,001 being made up of underrepresented participants from underrepresented populations in dementia research. This dataset has deep biological profiles and standard cognitive testing. With this information in mind, let's help you come up with a way to choose your fighter. First, you'll start with your research question. What is the most suitable point in adulthood for you to investigate your target phenomenon? What are the biomarkers you need? And I know that these are just very abstract, vague words, so I'm going to give you a visual to help you with this step. If you plot age on a continuum, try to, based on the literature you reviewed, based on your plan, try to define where in adulthood your target phenomenon occurs. Say, for example, in my study, this target phenomenon occurs between 60 and 80 years. Then come up with a checklist. What are pieces of information you want to know about individuals in the study that you need to know in order to be able to answer your question? Here you can see a sample list that I've just made up. Once you've done this, study the data sets. You will be able to find an overview of all of this on the Brain Health Arc website. As I've said, a lot of the links will be featured there, and I'm sure these slides will be wanted as well, so we can make them available if it would help. Go over the data sets and bear in mind that no data set will be perfectly suited to your data. This might be intuitive to some, but we must highlight it. Unless you curate a data set, it will not be perfectly suited to your specific examination. And as Jenny suggested, some trialists for VICTA, for example, will want to be able to confirm that the question is suitable. Take this step. Do not skip this. Take a moment to think about whether even the data set that most well meets your needs is suitable. Because you may have to, for example, choose between 2 data sets. You may have to make a choice between your checklist that we said. If not everything is available, you may have to take action with that, which takes me to the 3rd step of your action plan, and that is tailoring your research question to the target data set. Review any necessary adjustments. Here I just said, for example, some of the things in my list don't exist. Can I find a different way to synthesize the information I have available? Can I find a way to use the subgroups of the study to work around the information I am missing? Is there something I need to tweak about the specific direction or the specific characteristics of the effect I'm trying to quantify? These are the kind of considerations you take at this step. And the most important one, which please do not skip, tell us your idea. Even if it's not fully formed, come to us with your idea and apply before we close the deadline on the 31st of January. And that's me.